You have the floor.
Is he here? Let me try calling
I
him.
don't think he's around.
I
Can
now
we
put
start with Dr.
Dr.
Tarela?
Sarimiye is around.
Yes.
Okay, ma. So please, Dr. Sarimie, you can proceed with your talk
So he
on
can start first.
blood care and complication. Yes, ma.
Good afternoon, everyone. Good afternoon, my teachers, the Glaucoma Society of Nigeria executive, and the organizers of this program. Thank you for the opportunity to speak to you on the topic that is titled Blood Care and Complication. I'll be sharing my slides now, and we'll go on from there. I hope I'm audible, please.
Yes, very well.
Thank you. Okay. Are my slide visible?
Yes, also.
Okay. Thank you. So I'll be speaking on the topic blood care and complication. This should have come after the initial or the first speaker, but it's fine. The objective of this topic is to try and ensure that at the end of our discourse, we have an understanding of post-trabeculectomy blood care generally, recognize early and late complications, and learn practical management strategy. So basically, what's a bleb? We all know that a bleb is surgical procedure, or trabeculectomy, sorry. Trabeculectomy is a surgical procedure creating a new drainage pathway for aqueous humor from the anterior chamber to the subconjunctival space. The aim of trabeculectomy generally is to reduce intraocular pressure by bypassing the disease conventional outflow pathway. This had been discussed from the preoperative assessment and care that should be taken to intra-op decision making yesterday in this presentation that we've had. So coming to the meat of my discourse, what is a filtering bleb? This is a localized elevated mold of conjunctiva and tenon capsule complex that is overlying the scleral flap, which houses the ostium. It is a site where aqueous humor collects and is absorbed by the surrounding tissue and lymphatic system. Why is blood care crucial? The bleb is actually the lifeblood of a successful trabeculectomy. If the bleb fails, the trabeculectomy surgery has failed. So proper care directly impacts long-term IOP control and minimizes complications. And complications from bleb can be very minimal irritation to site-threatening infection. So how do we go about minimizing this from occurring and treating them when they occur? The ideal bleb itself has some characteristic. So the anatomical characteristic of an ideal bleb are that one, in terms of morphology, it should be a diffuse, broad, low to moderate height bleb that has a good extension posteriorly towards the fornix. In terms of vascularization, it should be relatively avascular. And in the situation where you may have mild hyperemia, if you have good multi-located microcyst, can still be classified as a good bleb. In terms of transparency, we want a thin wall, not cystic, but translucent, that you may visualize the underlying scleral flap. Location ideally should be superiorly. In the early stages of trabeculectomy trajectory, there were some trabeculectomy that were done in the inferior bulbar conjunctiva with its attendant complication, but such practice had been relegated to history. The physiology of a good bleb should ensure that the bleb will allow for good aqueous egress from the scleral ostium into the subconjunctival space. And this fluid should be able to be absorbed into the lymphatic channels that surrounds or within the conjunctiva and its surrounding blood vessels. In essence, a healthy diffuse bleb allows for efficient widespread absorption, not localized elevated bleb, but efficient widespread absorption, preventing this localized formation and attendant raised pressure over time. So with regards to immediate post-operative bleb care, the first 2 to 4 weeks, I will stretch it to say the first 4 weeks. The goal here is to optimize the bleb formation and prevent early hypotony or hypertony, because it can be the extremes that could occur. If you can maximize this early post-op care, the chances of a long-term success of your bleb is more likely. So what are the things that will help you maximize the care of the bleb in these first 4 weeks following your trabeculectomy? One is managing your inflammatory process. You want to minimize the inflammatory process as much as possible. And the standard care here is the use of topical steroid. So topical steroid in form of prednisolone acetate, especially if you have access to Predfort, then that's very good. Prednisolone acetate 1%, or difluprednate 0.05%, or dexamethasone. Those are options of potent steroid, topical steroid that should be used. And they should be applied frequently, initially for these first 4 weeks. Initially as frequent as hourly, to less likely maybe 2 hourly, but definitely not 6 hourly or 4 times daily at these first 4 weeks, especially in our eyes, the African eyes. Caucasian eyes, you may attempt to use it 6 times a day and the rest, but not with our own case. You should target hourly or 2 hourly for the first 1 month. And the essence of this is to reduce inflammation and the attendant scarring that could occur, which can lead to bleb failure. The use of topical antibiotics is very key. Now, the topical antibiotics is preventive and not treating any particular infection. So we are using topical antibiotics as a means of prophylaxis, given over 2 to 4 weeks. Some persons stop it after 2 weeks, but I keep on topical antibiotics for at least 4 weeks before I discontinue. And the common antibiotics you can use is the moxifloxacin antibiotics, can be used also frequently. Can give it 2 hourly or give it 6 times daily for that period before you discontinue. Cycloplegics are very key and very important. A lot of discourse has been mentioned about cycloplegia yesterday when we're talking about post-op complications and their need. Yeah, it's very, very important that you use cycloplegics in the form of cyclopentolate, homatropine, or atropine, anyone that is available. And why do we use this? It helps to reduce inflammation and pain, keep the eye in a cycloplegic state, help to deepen the anterior chamber, reduces the risk of also malignant glaucoma in those at risk of having it. And even the risk of having your iris incarceration. The AC is well formed, even though you have a PI, peradventure your PI is not wide enough, you can still have an iris track into the ostium. But having a well moved iris dilated and deepened AC, the chances of having these complications are less. And ideally, you use cycloplegics for at least the first 2 weeks, that you can discontinue its use. The use of releasable suture, or the advent of the ability to modulate sutures that have been applied over the scleral flap, is actually one of the recent advances that has improved successes following trabeculectomy, in the sense that where permanent sutures were placed, you may run into a situation whereby the sutures are too tight or the sutures are too loose. So sutures are too tight, you end up having hypertony in the early phase. High pressure, pale bleb may occur. Or if the sutures are too loose, may have hypotony. And in such situations, you run into problems. But with the advent of having sutures that can be modulated, this has actually reduced these from occurring. And this can be in the form of having permanent sutures that you can lyse later by suture lysis technique, either through Agon laser or Nd:YAG laser. You have the appropriate suture lysis lens, like the rich suture lysis lens, for example, or more commonly, releasable suture. And there are different techniques of applying releasable sutures. Putting releasable sutures also improve the chances of modulating the trabeculectomy outcome in the early post-operative period by modulating how flow the aqueous leaves the scleral flap. So what's the purpose of your, what's it called now? Releasing the suture at appropriate time. It's, first of all, putting sutures that are slightly tight in the first 1 or 2 weeks allows you to reduce the risk of having hypotony and its complication. But having an opportunity to release this suture at the appointed time now gives a better flow in the subconjunctival space that forms some level of scarring to modulate and reduce the risk of overfiltration. So by doing this, you help to improve the outcome of your surgery and survival of your bleb. It is advised for releasable suture that you tend to remove releasable suture not earlier than a week post-op because of the possibility of hypotony if you remove it too much. Now, you can use a 10-0 nylon too early, sorry. I use a 10-0 nylon suture or a 9-0 nylon suture. For those who use 10-0 nylon suture, it is advised that the releasable sutures are removed between the second and third week maximum following surgery, because after that, it may be difficult to remove the 10-0 nylon suture. It would have scarred down, and there is a tendency for the suture to slip and actually cut without releasing the knot. Using a 9-0 nylon can give you an extra 1 week that can stretch the releasability of this suture up to a month. But your knotting of the sutures intra-op also matters. For example, for the 10-0 nylon, you can use a 4-throw knot to keep it in place. For the 9-0 nylon, to have the same tamponade without over tightening the suture, you can use a 3-knot throw to give you the same effect as a 4-knot throw will give you for a 10-0 nylon. Digital ocular massage is actually something that is also very useful in the early post-op period. However, it should be done with caution. And ideally, at this early phase, post-operatively should be done in the clinic by the physician and not necessarily the patient. Usually, after the third, fourth week, and patients still need massaging, then you can teach them. So what's the purpose of digital ocular massage? Is to encourage aqueous flow, to break mild adhesions that are forming already, and to improve bleb diffusion. It helps to keep the bleb diffused and break any adhesion that is occurring that may cause restriction to the anterior bleb area. Technique, there are different techniques, but the technique I prefer is to apply your compression on the globe, either with your index finger or your thumb, over the lower eyelid while the patient is looking upwards. And this early post-op period, you do it under a slit lamp. You are visualizing the anterior chamber depth as you are massaging the eye from the inferior eyelid. You can see, and you're not putting too much pressure, just gentle pressure, because at this early phase 2, you still have good chances of the scleral flap freeing up easily. So you don't want to put too much pressure to have a flat anterior chamber overfiltration. You have conjunctival wound descent with too much pressure. So your pressure should be minimal, and you're visualizing under the slit lamp, and you see the way the AC depth slightly shallows from a very deep state, and you look at the bleb, you see a huge bleb. You can do this at clinic visits and see the patient frequently before you teach the patient, maybe in the third week to start doing it, or in a situation whereby your first post-op review, the pressure is slightly high, maybe you are getting 18, 19 post-trabeculectomy, and you want a pressure of low teens, but it's too early for you to remove your releasable suture. For example, you can do a gentle massage, bring down the pressure down to single digits, and follow the patient up. And at first week post-surgery, you can remove the first of the releasable sutures. What are the contraindications? They are obvious. Anything that does not warrant you to massage the eye is a contraindication. Hypotony. The patient may have elevated intraocular pressure but shallow anterior chamber. That's not an indication to do your massage. You worsen the shallowing of the anterior chamber and actually cause flat anterior chamber. Patient who has bleb leak is contraindication to carrying out digital ocular massage. Now, it's also important that in the first 4 weeks of your surgery, you have to have frequent follow-up visit for your patients. Now, your trabeculectomy could be done as a day case, or can be as inpatient case. For those who do trabeculectomy as inpatient case, may keep them admitted for 2 to 3 days, following the surgery to monitor the first two post-op day appearance of the bleb, the anterior chamber, and intraocular pressure. What are you trying to look out for? We have an idea that there is this phenomenon of slight overfiltration in the second or third day post trabeculectomy due to relief of edema that occurred intra-op and the rest. There's some slight overfiltration. So at that stage, you may have, if there's that overfiltration, you may have some shallowing and low pressure. So you want to see this patient frequently. So if the patient is on the ward, you keep them for like the first 2 days, ensure that everything is stable, then you discharge. If the patient is a day case, advisable you see the patient daily for the first 2 days or alternate day for at least 2 visits before you extend to weekly visit for the next 1 week. But this is not cast in stone. Each patient function, appearance, and need for intervention will determine how frequent you need to see them. It may even be more frequent than what I have mentioned. So, regards to the long-term bleb care, I just gave a brief run through on the early post-op bleb care. Regards to the long-term bleb care, we're talking about after 4 weeks and the rest. The major thing now you'll be considering is how to taper your steroid tapering. But we need to understand that for especially African eyes, patients are usually kept on steroid for a longer period of time before we actually stop. So ideally, it is recommended patients should be on steroid for at least 3 months, can be up to 6 months or more. However, in my own practice, my patients are on steroid for a minimum of 4 months. For the first 1 month, they are on hourly or 2 hourly. Then subsequently, I reduce for another 1 month. Then by the third month, 4 hourly. Then by the fourth month, I now taper off gradually. But this is also in relation to the function of the bleb I'm seeing in front of me, the appearance, the functionality. Have a good bleb, I may taper earlier. Have a poorly functioning bleb with increased vascularization, I may do other intervention while keeping the steroid on. We also know that the tapering of the steroid is also influenced by the intraocular pressure we are seeing, the bleb appearance, as I mentioned. And it's important to say that premature cessation of steroid is a recipe for bleb failure. The Caucasian eye, sorry to say, they tend to, most of them by 6 weeks, they've stopped their steroid. We can't try that in our eyes. Try stopping steroid by 6 weeks. That bleb in 6 months maximum should fail, or 1 year, unless we are dealing with very rare occasion where we have very thin conjunctiva and patient that scars very minimally. Because of our high keloid formation and fibrotic tendency, we tend to keep our patient on steroid for a longer period of time. Sometimes you may need to replace your steroid with non-steroidal anti-inflammatory, maybe from the fourth month, and you replace the non-steroidal anti-inflammatory for another 2-3 months before you discontinue. Sometimes while you're stopping is topical steroid, you may actually leave the patient on ointment steroid that they apply once at night for a longer period, all in a bid to try and modulate the outcome of your bleb to get a better or a successful long-term functioning bleb. And we also know that your post-op care, anti-metabolite is very important. From the intraoperative use of anti-metabolite, which was discussed yesterday, and there are different techniques. You can do the subconjunctival injection technique using your 0.02 milligram per mil mitomycin C or 5-FU subcon injection. Ideally, should be given 30 minutes to 1 hour before your surgery, or you can apply pledget under the subconjunctival space and under the raised scleral flap to maximize effect. Either one, literatures have shown success in them. I've not really seen literature in Black African eyes comparing both. Anyway, but literature has shown success in them. So after having that intra-op, you can still use your anti-metabolite post-operatively. Most commonly, 5-FU are given post-operatively. Occasionally, mitomycin C too can be used. And what is the need for post-operative anti-metabolite use? One, if you after your evaluation, you are what's going projecting a possible failure. The bleb may not have failed. You may just see early signs of vascularization that, if it kept, may cause failure over time. You want to target those vessels at that time. Such vessels onto the bleb, you trace them to their roots, where they are coming from the fornix, and you look for the prominent vessel there, and you inject your anti-metabolite around that area. Please, not into the vessel, but into the subconjunctival space, usually beneath the vessel if you can, and inject your anti-metabolite there. You can do that, and I can repeat 2 or 3 times at different intervals. Some persons give it at 72 hours intervals. Some persons give it daily for 3 doses. Some persons give it weekly. So different techniques are available. Some physicians actually preempt bleb failure by routinely give their post-op trabeculectomy patient maybe a subconj dose, a single dose of 5FU at 1 month or 2 weeks after, at 1 month or 3 weeks after surgery. Just give it there, but those are rare and in between. The main uses of them is during the presence of early vascularization that may connote possible failure if not tackled. And what is the concentration of the 5-fluorouracil that you can give? You can either give a 0.5 milligram per mil to a 0.75 milligram per mil. If you are using a vial that comes with 50 milligram per mil, that means 0.1 mil of that volume, give you 0.5 milligram per mil. If you want to give a 0.75 milligram per mil, you withdraw 0.15 mil and you give that using your insulin needle syringe with your insulin needle, which is a 27 gauge needle, can actually give the 5FU. And you can actually split this volume to 2 locations, depending on how the vessels are appearing. If you are using a mitomycin C, you can give a 0.02 milligram per mil concentration. We also need to understand that patient education is key. We need patients to note that the care for them, their glaucoma, and the care for success of the surgery is a lifelong thing. And in essence, so they need to have lifelong follow-up. Symptoms to watch out for, we need to clearly explain to patient pre-operatively, post-operatively, and at frequent follow-up visit as much as possible. Symptoms are very, very important. Things like redness, pain, or even just discomfort, discharge, sudden vision changes, maybe just blurry, not even significant drop in vision. Early signs that are uncomfortable, that are unusual, patients should report urgently and immediately to the eye emergency for evaluation. It's better to see them early and actually treat and prevent any significant complication from occurring. And we also need to advise the patient on care of their eye and their lid. Understand that in the first few weeks following surgery, they should not directly pour water on their face. They should not wash the face with soaps and water. They can use damp towel to clean the face area gently, because it's key at this early post-op period. The ocular surface is still prone to penetration by organism, and infection may thrive. So we want to reduce that as much as possible. Encourage the patient not to rub their eye for whatever reason. If they have discomfort, itchy sensation, they should come to the hospital. They are evaluated and proper care is given. They should avoid swimming in the very first few weeks and months following surgery, but much later they can attempt to swim. And even when they want to swim much later, they should be careful in the kind of water they go to swim in, and not just any kind of water they swim in. And they should have some protection in the early post-operative period. And more importantly, they should adhere to medication regimen, how it has been instructed for them to use, how it to be applied is key. That is why sometimes when you want to do trabeculectomy surgery, you evaluate the patient, you tend to ask for caregiver to be present, to counsel them together, because some situations they may not be able to apply these medications as frequently, as judiciously as you want them, and you want their caregiver to intervene to help them have the maximum outcome from the surgery by appropriate medication use post-operatively. So this is very key. So these are some of the counseling you give. And sometimes it may be difficult and Herculean task for the physician to do all this. So it's encouraged for a big ophthalmic practice that you have a counseling unit where people are trained specifically to counsel patients in detail. After you're giving your initial counseling, you send this patient for detailed counseling for them to have a better understanding of what the situation is and what is expected of them. So early post-operative complications. What are these early post-operative complications? I just classify them into 4 broad groups. You have hypotony with shallow or flat anterior chamber. What are the possible causes? Hypotony with shallow or flat anterior chamber and elevated bleb. The first one is with a flat bleb. The other one is with an elevated bleb. Third, high intraocular pressure with deep anterior chamber and low or flat bleb. The fourth is high intraocular pressure with shallow anterior chamber and low or flat bleb. So the key here is looking at your intraocular pressure, looking at the bleb morphology, and looking at the anterior chamber depth. Having these 3 parameters in place, there are different possibilities that could occur, and they are broadly grouped into these 4 categories, for which I'll pick a few of them and we'll discuss. So the first early post-op period, you may have a bleb leak, which causes the number 1 categorization I mentioned, where patient will have hypotony. Patient may have hypotony, shallow anterior chamber, low or flat bleb. In this situation, you need to suspect bleb leak, and the bleb leak usually will be significant. And what are the possible causes of this bleb leak? It may be from uncharacteristic or non-judicious care during intraoperative period. There may be a large buttonhole that may have been missed. There may be poor wound suturing at the limbus with resultant wound dehiscence, and that may have occurred when you are reviewing this patient in the early post-op period, that may even cause conjunctival retraction that you would need to handle. So these are possibilities that may have that may cause bleb leak. And the hallmark here is Seidels positivity. And in this situation, what do we do? It can be conservative, or you can actually intervene surgically. So conservative care now also depends on the extent of the leak, the extent of the shallow anterior chamber. So if you have a leak, the anterior chamber is formed, not necessarily shallow or slightly just shallow, you may be a bit more conservative. You can put pressure patch, 12 hours or 24 hours pressure patch over the eye and release and reassess. You actually put a wide bandage contact lens. It's ideal that you use at least a minimum of size 16 millimeter diameter bandage contact lens. Or sometimes it's difficult to get these, and you may be left with using a 14 millimeter diameter contact lens. But a 16 or 18 millimeter diameter contact lens is what is more appropriate. It has a wide area that the significant part of the bandage contact lens is resting on the bleb surface, giving you the tamponading effect that you require to encourage healing. So you need to do that. You may sometimes decide to give aqueous suppressant to reduce the flow rate to allow for healing. Some people have talked about autologous blood injection, but I have not seen that, and I don't know if any of my seniors listening have done or have used it. Surgically, you may decide to do bleb revision. You can go and just suture the spot at which the leak is coming from. At the limbus, you may decide to now put multiple mattress suture close in between, not long mattress suture, to close up that place. And it should be a permanent suture this time. When you are going to repair a bleb leak, it's not the time you use a absorbable suture. You use a non-absorbable suture, like a 9 or a 10 nylon, to properly seal that place, and you know you have sealed the conjunctival point that is leaking from properly. Sometimes, if there is a conjunctival retraction, you may need to actually do proper bleb revision and do a conjunctival advancement. You need to open up a bit and pull fresh conjunctiva to have a good apposition and suture properly at the limbus. So you may also have excessive filtration. In excessive filtration, what are the things that the patient will present with? Patient will present with a huge bleb. Patient will have significantly huge bleb, hypotony, and shallow anterior chamber. When you see this combination, okay, this most likely this person has excessive filtration from either a loose scleral flap suture, or less commonly maybe when we too early remove the releasable suture. That's why it's advocated that releasable sutures are removed not earlier than a week after surgery. Second day, you're having a pressure of 18 or 20, as I'm not really comfortable with this pressure, and you remove releasable suture, and pressure goes to 2 or 0, and you see a huge bleb. So that's also a possibility of having or a cause of overfiltration. So this condition usually resolves spontaneously with appropriate medical treatment. And what are these treatments? Cycloplegia, use of atropine, you're deep in the anterior chamber, can use a wide bandage contact lens to cause tamponading effect and allow for some level of healing. You can reduce the frequency of steroid use for a short period of time to also allow for healing. You can apply a pressure patch over the eye for 12 hours or 24 hours, all to allow some level of healing. And all these are done in a way to conservatively manage the overfiltration. However, if the overfiltration is not resolving, or you have practically a flat anterior chamber, you need to surgically intervene, because we also know that hypotony with shallow anterior chamber is a risk factor for malignant glaucoma. So the AC is too shallow or flat for a long time, patient may develop malignant glaucoma, aside from all the attendant problems that may occur from flat anterior chamber, corneal decompensation, cataract formation, peripheral anterior synechia, just to mention a few. So we need to deepen the anterior chamber. So the simplest of the surgical intervention may just be to inject a visco elastic substance, preferably to inject a viscocohesive, not a viscodispersive. You want something that will sit within the anterior chamber and stay there for 72 hours or more, not one that disperses easily. So cohesive is better option than a dispersive. And the question will now be, okay, what's the volume of visco do I need to inject? Do I need to inject to deepen the AC? In this situation, you don't want to deepen the AC. You just want to reform the AC, because you understand that as you keep injecting visco into the anterior chamber space, what happens? The visco will keep spreading and will look for area of least resistance. Remember, your scleral flap is loose. The scleral flap is not properly apposed, is not having tight apposition. What happens when you push too much visco into the anterior chamber? Some of those visco will pass through the ostium and go underneath the scleral flap. The flap that you want to allow for healing will now be straddled by viscoelastic in between. That will even keep it open for a longer period of time. So you have a vicious cycle. So in that case, you have to form the anterior chamber appropriately, or you're not targeting to deepen the anterior chamber, because you're doing that, visco will start going into the bleb, and you have a cycle of overfiltration that will last longer. Sometimes you may go ahead and put what we call mattress, conjunctival compressed suture over the bleb area to put direct compression on the scleral flap. That's another option that could be done. Or you do a bleb revision. Open up the bleb and put a tighter conjunctival, tighter scleral flap suturing. Tighten the flap better. You can still put a releasable suture, but tighten it much better. When the AC is well formed and everything is well controlled, you can release such sutures. So those are some of the surgical interventions that can be done. Now, you can also have underfiltration early post-op, where first day, first week or 2 weeks time, you see pressures already high, low-lying bleb, reduce posterior flow. This bleb is already failing if you don't do something critical about it. And in this case, it's primarily because the scleral flap suture is too tight ab initio. But if it's the first 1 or 2 days, you may also suspect sometimes a blood clot may be blocking the ostium, fibrin membrane may be blocking the ostium when you see this patient first 2 days following surgery. And you can do a gentle gonio to examine the ostium, and you may actually see, and a gentle massage will break off either the fibrin membrane or the blood clot. However, a third possibility that may be because of underfiltration is when you have a trapdoor effect at the ostium. where your deep block was not properly done, you did not excise through and through the deep block, the deep scleral tissue out. You have a tiny thin flap that easily moves, open and closes. So when you are operating, it opens and the AC a bit formed, bleb looks well formed, you close. But over time, it falls back and closes the ostium and pressure rises. You do gentle massage, fluid gushes through the ostium, and you have a huge bleb. 1 hour later, you see the pressure is climbing. You look properly, you will see that you have what is it called now? An incomplete deep ostium formation. And in that case, you may need to go back and do a revision to to complete that excision. But it's better to prevent this from occurring. So intraoperatively, it's better you have a complete deep block removal of your scleral tissue and not leaving a fragment that forms like a trapdoor effect. Okay, aqueous misdirection is also another early complication and it can occur early to several years later. Now, there are some possible risk factors, but what is actually aqueous misdirection or malignant glaucoma or ciliary block? There's reversal or backward direction of the aqueous, which is from the ciliary process in the posterior chamber, but instead of coming to the anterior chamber, it finds its way in the posterior segment into the vitreous space and it builds up vitreous volume, and that volume pushes the iris lens diaphragm anteriorly. So you now have shallowing, a uniformity, the appearance of shallowing of the anterior chamber, great intraocular pressure. In this kind of situation, sometimes you may be able to predict possibility of people who may at higher risks of having it. And one common group of people are people with primary angle closure glaucoma, people with small globes generally, or non-ophthalmic eyes generally. They have the higher risk of having malignant glaucoma. And it is key, if you notice that if you do a pre-operative laser PI, tend to reduce this risk a bit more because the anterior chamber, for whatever it may work, it appears as if you are bringing it to a normative state of how it should be before you do your surgery. Now, aside from someone who has angle closure glaucoma, post-operatively, you can also actually induce the possibility of malignant glaucoma. If there's any cause of a sudden shallowing of the intraocular, of the anterior chamber space, cause of sudden shallowing, you may actually have aqueous misdirection. Where for something like removal of releasable suture too early and you have shallow anterior chamber overfiltration, that may induce aqueous misdirection. So you need to take care of not removing releasable suture too early. And the IOP may be normal or high because it starts from gradual build-up. So you see the patient early enough, you may be seeing a normal intraocular pressure. Other parameters will point out to the fact that this person actually have early form of malignant glaucoma. So someone that have normal intraocular pressure, you can see the anterior chamber is shallow, and yet the bleb is not looking huge. You need to weigh in the possibility of malignant glaucoma in the presence of a patent PI. Looking at all these considerations, you think of malignant glaucoma. So how do you manage this patient? Initially, aqueous suppressant, the aqueous suppressant is not just to reduce aqueous production, but those that also influence possibility of shrinkage of the vitreous. So the use of acetazolamide stops in this place because aside from reducing, suppressing aqueous production, it tends to also have effect on vitreous volume shrinkage. So use aqueous suppressor like acetazolamide, use frequent cycloplegics, atropine to try and push the iris lens diaphragm back and to reform the AC. And the possibility of pushing that iris diaphragm back tend to reverse this aqueous misdirection. And some authors have said that this can actually cause resolution in about 50% of patients with malignant glaucoma, especially when they are picked very early or when they have very high intraocular pressure. Surgical management depends on the state of the eye that is being considered. For someone who is a phakic or pseudophakic, a straightforward laser destruction of the anterior hyaloid face with having a posterior capsulotomy to convert the eye into a unicameral eye can reverse malignant glaucoma from occurring. Now, when these options fail, or for someone who is faking, he has his natural lens in place, and medical therapy had failed, they actually go for pars plana vitrectomy that goes in to disrupt the anterior hyaloid face, and in the bit of disrupting the anterior hyaloid face, they reverse this aqueous misdirection. Some persons have in the past have used vitreous tap technique to try and tap some vitreous. Sometimes they may be able to tap the position where the aqueous in and pull out aqueous from the vitreous. But the high tendency of recurrence of the malignant glaucoma is very high in them. And secondly, the vitreous tap usually done blindly unless you are doing it under ultrasound biomicroscopy, where you can see the area of collection of the aqueous within the vitreous. And even with that, it's really not really permanent. Pars plana vitrectomy may give you a better solution. Sometimes you may actually even do a cataract surgery with pars plana vitrectomy to resolve this process. But it's also important to note that patients with malignant glaucoma, they may be on cycloplegic for a long time, maybe at very low frequency, atropine once weekly, or even a few years, because it has been shown that stopping of the cycloplegic too early may cause a recurrence of the malignant glaucoma in that patient's eye. Also, we need to understand the patient who had malignant glaucoma in one eye is at a very high risk of having malignant glaucoma in the other eye. So all precautionary measures need to be taken, and all proper information also need to be given to the patient. So this is just a summary of discussing seeing and shallow anterior chamber and pressure, whether it's low or high. What are the values you see? What are the possible causes? How do they present? And what are the available treatments? So other complications that are bleb related that we may see post-trabeculectomy include things like encapsulated bleb, also referred to as tenon cyst. Feature, why does it appear? Tense, localized, dome-shaped in appearance, common in younger people because of the increased risk of fibrosis and failure rate. IOP rise due to restricted flow. There's restricted posterior flow of the aqueous, and so it restricts the extent to which the aqueous can diffuse, and of course, pressure control is minimal. So what's the management that is available? If it's picked early, whereby you may not even have a doom appearance yet, you just notice that your bleb height is less, and more posteriorly, you're not really seeing the elevation you want to. The surgeon knows how extensively he or she has dissected the subtenon space posteriorly. I tend to dissect very wide area post because I want a wide diffuse bleb. So when you look at your bleb post up and you are not getting that good posterior flow, this is a recipe of encapsulation later. The pressure may be in the mid-teens at the time you are evaluating, but because you are doing proper bleb evaluation at every post-op visit, you pick it early, you do ocular massage, and you tend to break these early fibrotic changes that are forming by your massaging technique, and you keep it open. That's one method that one can actually do. Secondly, if it's more pronounced, you can do needling and anti-metabolite. But however, in our experience, we found out that success rate of an encapsulated bleb with needling and anti-metabolite is practically less than 50. Sometimes you may need to repeat it 2 or 3 times, and even with that, you may still need to place the patient on medication or do a different surgery. Some people advocate for actual revision of the bleb, go dissect and even cut off some of the fibrous tissue, but this is just a recipe for temporary solution. The primary cause of that inflammation is still there. The aggressive nature of fibrosis in this eye, most likely after doing such extensive dissection, which you have incited more inflammatory process, it will still fail. So we may not even want to go to that extent. Place the patient on medication, decide to do a second surgery in the form of maybe a glaucoma drainage device surgery may just be the option. Late post-operative complications. With the advent of anti-fibrotic agents that we all know, we know that we are achieving better intraocular pressure. However, with this better intraocular pressure control, there's now increased risks of late complications, such as chronic hypotony, bleb leaks, blebitis, or outright endophthalmitis occurrence has been shown to increase. So chronic hypotony, this is not early hypotony that occur in a later stage and remain for more than 3 months. That's when you define the hypotony to be chronic. And this is said to be associated with a drop in the visual acuity and hypotonic maculopathy. In the case where you have thick edema and folds in the macular area seen in this picture. So seen in this picture. So the risk factor for this complication are younger people and who are also myopic in the first place. They have increased risk of having this myopic patient in general. So most related to decreased scleral rigidity in the area of the posterior pole and a tendency towards collapse and the presence of a low IOP. The non-surgical intervention for chronic hypotony includes use of wide diameter bandage contact lens to have a tamponading effect. And some people have even advocated the use of gentamicin drop that it has been shown to incite some subtle inflammatory occurrences, may be added to having a wide bandage contact lens. And some persons have advocated the use of cryo treatment in the peripheral area of the bleb to induce some level of fibrotic changes that reduces the extent to which the bleb is filtering. Autologous blood also mentioned they have not tried it, and I'm sure my seniors will discuss more on this. Most of the time, the results are inconsistent when you do all these techniques. Surgical revision may just be the way to go, and it includes actually use of scleral patch to cover a flap that is decent. Sometimes the overfiltration or the hypotony that is as a result of scleral melting or the use of antimetabolite, you need to use a fresh scleral flap, cover that area. We actually do compression mattress sutures, like in this case, to try and put compression effect over the area of the scleral flap, or may actually seal up the place completely where you feel you are not winning. Put several sutures, go back and put several sutures underneath over the scleral flap to close it up. Those are some of the interventions that can be done. Bleb-related ocular infections. I think I've spoken for quite a long time. Let me just rush and finish. Bleb-related ocular infection. Blebitis to bleb-related endophthalmitis. So we can have stage 1, stage 2, stage 3 of blebitis. Stage 3 blebitis, also referred to as endophthalmitis. The infection usually starts in the subconjunctival space and spread to the anterior chamber and then to the vitreous. The onset of infection vary, can be from few days to several years following the filtration surgery. Hence, your patient that a heart trap is your next best friend for the rest of his life, in the sense that he needs to follow up for the rest of his or her life. What are the risk factors for having bleb-related infection? Thin-walled bleb that is leaking, myopic patient, the presence of releasable suture that has not been removed over time may give a nidus of infection that may now track into the bleb, concurrent respiratory infection, unguarded filtering surgery, whereby the surgery itself was not properly done with the best of aseptic technique, thin-walled bleb that is commonly seen with antimetabolite use and those with diabetes mellitus. All these are people with risk factors that may increase the chances of having endophthalmitis. Now, the reported incidence has gone from 2%, some people have even reported up to 4 or 6%, which is higher than the infection endophthalmitis related to cataracts. The morbidity of infection can be very high. Almost 1/3 of bacterial infection following filtering surgery that were treated with intense medical treatment ended up with no light perception. So it's something that we, as much as possible, aim to prevent than to try to treat. We try to prevent it from occurring as much as possible, because treatment sometimes is quite difficult to have good results following treatment. Common organisms include streptococcus, staph, and Haemophilus. They are usually ocular surface flora. They are the common organisms that are cultured, if they are cultured. Symptoms include pain, foreign body sensation, and the rest. And typically, the bleb will have a milky white appearance with loss of clarity. It may be associated with bleb leak, hypotony, or vitreous reaction, depending on the extent. And as I mentioned, can be stage 1, stage 2, stage 3, depending on the extent of involvement of the intraocular area. Now, any conjunctivitis and periitis should be treated promptly. Anybody that has it. For someone that is a patient we saw like 2-3 weeks ago, this is a patient that had glaucoma during device surgery, only eye patient, a young lady, came with conjunctivitis. We actually admitted her and ensured we treat the eye properly, not because we are treating endophthalmitis, but this patient is a high risk patient for further progression into outright blebitis and endophthalmitis, and is an only eye patient with very advanced glaucoma. So we have to be very aggressive in managing these kind of patients. So depending on the stage, we also depend the extent of intervention. For the stage 3, that's the outright endophthalmitis. Of course, we want to be aggressive, give intravitreal injections with vitrectomy as early as possible when needed. Maybe after the first intravitreal, if you're not getting resolution, you go and do postplanar vitrectomy to remove the core of the vitreous and actually remove the volume of the offending organisms within the eye and inject your vitreal antibiotics. Of course, you have to work in close proximity with the retinal specialist when managing this kind of patient. Dysesthetic bleb also is another post-op complication. It's a common presentation, bleb that is symptomatic. And the symptom can be foreign body sensation, can just be irritation, can be feeling of dryness, or just appearance of prominent bleb that is comforting. That may just be what the patient presents with. How do you manage lubricants? Lubricant goes a long way in giving the patient comfort, because this dysesthetic bleb can also form Delin, and the Delin also can induce more dry eye symptoms. So just lubricant alone can suffice. Sometimes you can use soft bandage contact lens to ameliorate the doom division of the bleb, especially when it's cystic, or we can actually go and do a bleb revision, and that is in severe cases. So in closing, patient education and empowering self-care, we need to have this concept of a bleb report card, whereby we teach the patient what is a healthy bleb looks like generally, and what is the warning sign. But most of our patients, they stand in front of the mirror and they raise their eyelid and they're looking at the appearance of what is this thing that they and things like that. So don't give them an idea. It should just be diffuse, it should not be red, it should not be milky, just normal, maybe mild red if it isn't red at all. And that's what they expect. When they say anything different from that, they should raise suspicion and they should come immediately. If it is anything like sudden redness, pain, discharge, blurry vision, they should present. Headache, nausea, and they should also know the importance of hygiene to avoid rubbing the eye, to not swim in water that you're not clear, you're not sure of, even years after your surgery, as much as possible. Medication adherence is
Thank
key.
you.
Long-term follow-up is key. So in conclusion, successful trabeculectomy outcome is actually heavily dependent on meticulous bleb care. A thorough understanding of bleb morphology, physiology, and potential complication is essential for every glaucoma specialist. Early identification and prompt management of complication are critical to preserving vision. Management includes medical, laser, surgical approach. Patient education and engagement are paramount for long-term success. Thank you very much for the time.
Thank you so much, Dr. Seremiyu, for this elaborate and extensive discussion on bleb care and complications. I would like to call on the second presenter, Dr. Nathaniel, to please share his slides and go on with the presentation, because we are short of time. It's already past 5. Thank you very much. Dr. Nathaniel, you have the floor, please.
Hello, Dr. Nathaniel, are you with us? He actually sent a private message saying he had an issue with the Zoom on his laptop. So I don't know if it's been resolved. But assuming it's not,
So,
Dr. Sarimiye did such an extensive job. So I think he even covered both topics in most of the places.
Yes, ma.
Yeah, he actually
Yes.
covered both topics, post-op complications and blood care. So,
Yeah.
Dr. Nathaniel, if you're able to present, please do. If you're not, maybe you can just send it to the platform and then we can share it for others to have a look at. So we can take the questions and answers. Yeah.
So on that note, if I have your permission, ma, maybe our panelists should just share some experience based on the discussion we had thus far from the Dr. Sarimi's presentation, while we are still waiting for Dr. Nathaniel.
Okay, Professor Bola Adekoya can start.
Then Dr. is round up so thank you so much, Dr. Sarimi. Hope I'm audible.
Yes, ma, you are.
Yes, yes, we can
Thank
hear.
you. All right. Thank you so much.
Can I
Dr.
share my this thing without?
It's been a
Yes,
very
please, ma. It's like Dr. Nathaniel is ready.
Oh, all right.
Yes, ma'am. So please share your slides and let's go.
Hello, Dr. Nathaniel. We are waiting for you.
Can I share?
I think
Yes.
well,
I'm trying to. If they don't make me the host, can I share?
Yes, you can share. Please go
Can
on.
I share my screen?
Yes.
Oh.
Dr. Nathaniel, we can't see anything from you.
I'm coming. Okay. Uh, kind of network this one now.
Can we be having the panel discussions while you're trying to sort it out? So that at least we'll buy time.
Yes,
And
I
then
think I agree.
if it actually comes on, yeah. Please.
Yes, after that.
Okay. All right.
Dr. Nathaniel. All right.
Okay.
So once again, I want to thank the presenter, Dr. Sarimi, for this very, very extensive and excellent presentation. We covered almost every significant part of this topic. He has done excellent justice to it. And I also want to appreciate the GCN. I also want to appreciate GCN leadership for putting this together. So from pre-operative preparation, surgical aspect that from what is we discussed in the last 2 days, we know that they are very, very important in trabeculectomy. And the post-op period is also equally very, very important. And a poor post-operative care can spoil and even an otherwise good surgery. So we have to be actively vigilant. Actively, that's the key word. actively and vigilant during this period. So it's not the time to go and relax. Well, we definitely will relax, but definitely want to be on the lookout for any potential complications. And it's not, I would say, it's something that is highfalutin or something that is difficult that we cannot do. It is something that is very, very, very much doable. Once we are committed to it, it's something that actually that we can actually follow through very, very easily. And so we should endeavor to evaluate our patients systematically at every encounter as selected by our presenter, Dr. Swahili. So, and we must know when we evaluate this patient what exactly each of those parameters, what they need. So the visual acuity, the conjunctiva, if there is a drop in visual acuity, the conjunctiva, not only the bleb but the other conjunctiva, very bleb area, the anterior chamber, the PI, the lens, the intraocular fluid, etc. And of course, not forgetting endoscopy. So we must be systematic. So if we are systematic and we know exactly what can go wrong in each of those evaluations that we for our patients, then we'll be able to know, be able to spot problems on time and be able to act on it. So also a very, very important thing is that our entire team must, because not sometimes, of course, we are not, if we, of course, if we work as a solo practice, maybe that is easy. But if you work in a group practice or like in a teaching hospital or even the secondary or to a general hospital, we have other things working with. If you have done the surgery, you must not, you shouldn't just leave the postoperative care to other people to do. We must be actively involved, or they must also be actively involved in conservative care of this money because one simple misstep of not adequately catching these patients at the right time can can prove very very injurious to the best outcome that this patient may have. Another important point that I also like to raise is that an adequate patient education is so, so important because it has the potential to adversely or positively affect the surgical outcome. We know this patient must understand what what is going on and what is what the long-term benefit is for them. So educational leaflets, educational videos, our counselor, peer support, all these must be reiterated at a regular clinic visit. And of course, some of our patients that we operate and then we maybe in 1 week into they come the first day, then they come maybe the first week, and then after we can see them again. That's part of being actively vigilant. We may need to call them. Otherwise, by the time these patients come back, a lot might have happened. There might have been some psychiatric complications that might have easily been remedied if the came early will have occurred. So that's why sometimes in our practice we call out our patients. We haven't seen you this your last appointment, this your last two appointments. And that helps. But a lot of them say, oh, doctor, I don't have time. But when you call them, they come. So it may need a little bit of going the extra mile on our part, which is part of the care that we offer our glaucoma patients because they are special. So it's very, very important. And of course, at the finally, just what I want to say that we should also seek peer help and peer advice if we encounter problems that we think we might not be able to cope with. There is the GCN is a great platform for this. It's, of course, we have educational platform. Maybe I don't know. The national has a separate educational platform. Maybe GCN should have a separate educational platform where we post cases, we post. But even these are current platform can also serve as such. So you should not hesitate to seek for help, to seek for advice, to seek for second opinion if we think there's something going on that we're not able to take care of or to completely manage on our own. So I once again very excellent presentation by Dr. Saraniye. Thank you so much, everybody.
Okay, thank you.
Thank you very much, ma.
So I will just give my own comments while we're still waiting. Dr. Nathaniel, if you can't get it up, don't worry. You can just send it to the platform and we'll look at it there. Okay, so thank you so much. Very, very important discussion that we've had today. Like Professor Adekoya has said, you can do a very good surgery, but if your post-op management of this patient is not optimum, you would have just wasted time and even worsened the patient's problem. That's why trabeculectomy is not a surgery you do and then just go to sleep. if you know you're traveling or you don't have time to follow up your patients, it's better you don't start the process. I don't believe in handing the patients over to other people to take care. You have to be actively involved in the process. So even if you have the other doctors, residents, you have to be actively involved, because if you pick up things early and start to mitigate them, then you will be able to save the bleb, and therefore you will save the surgery. I'm just going to give two actual life scenarios that happened to me last year, two trabeculectomies at different times. The first patient was, I think she was like a 50-year-old, and she had bilateral trabeculectomy. So I did the first one a month before. The patient was very scared. She had the first one. And incidentally, it's all this kind of 0.99 eyes that I have the misfortune of meeting. So I did the first one, and she was seeing very well. And she was like, is this easy? And I gave her all the instructions. Don't do this, don't do this, don't do this. And she did very well. She obeyed all the instructions. And then at the end of the first month, when I was sure that this other eye had settled a bit, I now did the second eye. And because for the patient, she felt that this wasn't a big deal. 1 week after I saw the patient, I saw her on a Thursday, because I see my patients weekly. I actually see my patients weekly for 6 weeks. And thereafter, 2 weekly, I see them as frequently as I can. So I saw her on a Thursday. This was her second week post-op. Her visual acuity was 6/9 on a Thursday. AC fine, bleb fine. Then I saw her in the clinic on a Monday. And I'm like, why are you here? You're supposed to come back in 1 week, which is the Thursday. And she said, doctor, I can't see. I put her on the slit lamp. What did I see? Hypopion. Almost like full chamber hypopion. What happened to you? I saw you on Thursday and this is Monday. Basically, like 3 or 4 days in between. She went to the market. She had to cook. She came back. She was pounding pepper and onions. A little flew into the eye, and that is the story. I was like, God, well, you've been given instructions not to do all these things. And we started fighting with endophthalmitis and co. At some period, I lost her. She became full cataract, LP. I truly don't know what ever happened to her again, because she just stopped coming. That's one case. Then the second case, this happened 2 weeks post-op. The second case is somebody that had TRAB, and 1 year after surgery, he calls me over the phone and said, oh, I had a little bit of discharge. I noticed that I had some red eye and pus. I said, run to the hospital now. As you drop this phone, just run. And he ran and came, and there was like 10% hypopion already in the eye. This is 1 year after surgery. So we started intravitreal treatment for endophthalmitis. And 1 week after, the whole hypopion cleared, everything was fine. But the next thing we now noticed was choroidals. He had hypotony, he had choroidal effusion. We treated and treated. After a while, pressures came back. By this time, patient already had a cataract. So the cataract just got worse. But luckily, the patient has had a cataract surgery done, and he's now 6/18 on that eye. So we were able to save the eye. Obviously, by the time all of this was happening with the cataract and the endophthalmitis, it was light perception. So that's why I say that trabeculectomy is not something you can just do and go to bed. It's something that you have to have a close contact with your patient for as long as possible. So most patients think that once they have surgery, they have been cured. So you must let your patient know that they still have to be coming for follow-up. You've been able to control your pressure. That is just one aspect of the disease, but other things can go wrong. And if you don't come for follow-up, you may not be able to pick these things up. So please, like you said, it is everybody's business. We're putting our hands together. We're making sure. Thank God I had a retina specialist, so you need to work with every other person. It's not a one-man business. And at the end of the day, the patient is the most important thing, and preserving the patient's vision is the most important thing. So this particular second patient was also a 0.99 eye, but now at least he's a 6/18 vision and he's a happy person. Like I said, I don't know what happened to patient A, but luckily the first eye that had TRAB was 6/9. And hopefully she's still 6'9", and so she's been able to save one eye. So that brings us, Dr. Nathaniel, before we end, I don't know if you're ready.
Suma, can I say something?
I can see
So there are a
somebody's
few
hand up.
hands.
Yes.
Yes, please.
Yes, I can see your
Comments
hand. Please,
are
you have the
welcome.
floor.
Today is yeah.
There are
Today is the
some
last day,
questions.
so
I
yeah,
think we should
comments.
take those questions.
Question.
Okay, I think Dr. Sadiq wants
Okay,
to say
ma.
something, and then I'll hand over back to the moderator who will take the question.
I also want to say
No.
something.
Okay,
Hello?
Yes,
please put
ma.
your hand
Dr.
up.
Professor Olusola, you have the floor, please. Yes.
Oh, okay.
Okay,
A few
Olusola,
questions
well,
are there, and I think we should look at those questions and answer them. Would you want to do that
Yes,
first
ma'am.
before we have the final discussions and then we end?
Thank you.
Yes, ma. Let's answer the questions first. Dr. Sarimi, I have about 6 questions that was posted on the chat box. The first one says that
Sorry.
Yes, ma'am.
I sent my this thing. I having issues with I don't know whether internet. Hello.
Dr.
We are
Nathaniel is
with you.
fine.
We are
We've
hearing
heard
you,
you.
Dr.
It's
Nathaniel.
okay. It's fine. It's fine. You can send it to the group. We'll look at it there. Thank you.
So the first question goes like this: that how often is the frequency of DOM, digital ocular massage, daily or more than twice? Dr. Sarimi, please.
Okay, thank you. Now, the ocular massage is dependent on, or how frequent is dependent on when post-operatively you are doing the ocular massage. For example, if it is first week post-op and you have a pressure of high teens, or you want the pressure to be lower, you are not ready to remove your releasable suture. It's just a single massage at the slit lamp that you do at that time, and you see the patient at your next scheduled visit. Now, if it is like 3-4 weeks later, you remove releasable suture, your pressure is suboptimal, but you feel with massage you can break any fibrosis occurring, then this will be frequent. This is the time where you now teach the patient how to do the massage appropriately. This is like few weeks post-op. But for the first 2-3 weeks, you are the one doing the massaging at clinic visit based on your determined time to see this patient. So there's no cast in stone time that must be twice a day, 3 times a day, once a day, or something like it. Depends on what you see, what is your aim, and what is the expectation from the massage that will determine how frequently you want to do it. But as I mentioned, if it's within the first 1 or 2 weeks, you are the one doing the massage and to be at your clinic visit. It can be one in every 2 days that you are seeing the patient, but it can be just once and you see the patient next week, depending on what the pressure is and where you want the pressure to go to. I hope that clears the question.
Yes, okay. Thank you very much. And the second question says that how will you advise for the use of low dose oral steroid like 10 milligram BD in the immediate post-op, as some patients might not be compliant with your hourly, 2-hourly, or 3-hourly steroid?
I think people have different opinion to this, but I would want to say that low dose systemic steroid will not have much effect on your blood healing per se, low dose. And as much as possible, you want to avoid giving systemic steroid unless you are dealing with children. And even with children, you calculate the oral steroid you are giving per kilogram body weight. So it's not just giving 10 milligram BD for an adult. That will not really give you what you want if you even want a systemic steroid effect. If you want to do that, then you should give your potent steroid 50 milligram or 70 milligram daily for 1 week or alternate day for 2 weeks. And you're sure that's why you are giving it. But as much as possible, try to avoid doing that unless they are high-risk patients and you are really, really sure that this patient will not really be compliant with very frequent steroid use. And if that is the case, and the patient is also appropriate for glaucoma drainage device surgery, why don't you give that as an option? Because for your tube surgery, you tend to have the need to use frequent steroid is not as strong as that of trabeculectomy. So there are other things that you need to consider, but 10 milligram BD, I'm not sure. Maybe my seniors can answer. I don't think that will give you the steroid cover effect you need for the bleb not to scar down. Thank you. Next question, please.
Professor Adekoya, please, can you shed more light on this before we move to the next question? Hello, ma. Or I should just go to the next question?
Hello.
Okay, she's here.
Yes, ma.
Okay.
Yeah.
All right. Yeah, I'll give Dr. Sani that low dose steroids may not be negligent. Sometimes it may be just like giving water. It's not if you are giving steroid, you want to give steroid at maximum dose. Even as it starts, when you're starting, you start with steroid at maximum dose. So you not really very much. And we know about ocular penetration of many medications that is not really that good. So it may not take much. So most of the time, maybe it's used as a placebo, at least to the best of my knowledge. Except if you give maybe very high dose at the initial stage. I want Dr. Sani to please comment on the use of either subtenon or conjunctival injection of depot steroid for patients that think we need that extra kick of anti-inflammatory agents, maybe in the post-operative period.
Okay.
What should we do?
Okay, I think yeah, I don't agree with the systemic steroids, except they are high, you'll be wasting your time and the patient's time. And obviously, if you give high steroids, you're going to end up with systemic side effects like increased blood pressure and blood sugar fluctuations. So another thing you can do is depot steroids. You can give depot steroids, and then maybe reduce the frequency of the topical steroids. But you definitely need steroids on the eye itself. So one thing you can do is depot steroids, but I would still say that you would still need topical steroids, but maybe not as frequent as 1 hour if you've been able to give depot steroids. Thank you.
Okay, thank you very much, ma. The next question
sorry,
says,
please. I just need a clarification.
Yes,
This is
ma.
Professor, not Koya.
Yeah.
The reason why we
Yes,
are
ma.
thinking of this systemic steroid is that because patient is non-compliant or there is a risk of failure. Maybe we notice that
the person that has
some
question says
fibrosis.
that because of
Yeah, so
she said that because if patient is not going to comply, it's for non-compliant according to the person that asked the question.
Okay, so I agree with Professor Awoye Tupu then. I don't think we should be loading our patients. Easily, people develop diabetes. And before you can have a reasonable effect, you have to give a higher dose, which we have other means of achieving. Thank you. So the depot, yes, is another way of doing it. Thank you.
Thank you, Prof. Ma. The next question says that for a failing bleb, where should the antimetabolite be given? Into the bleb or adjacent to the bleb? Dr. Saremiye, please.
The antimetabolite should be given adjacent the bleb, actually as far away as possible from the bleb, but you are targeting a location. You are looking for the offending vessel, the vessel that is bringing the inflammatory agents to cause your failure. So you look at the area over the posterior, beyond the posterior part of the bleb, superiorly, nasally, and temporally, and you look at it very well. Then you give your antimetabolite around the area where you feel the offending vessel is coming from. Now, in a situation whereby you have encapsulated bleb 2, for example, you give your antimetabolite away. Some books say as far as 180 degrees, but I tend to say maybe like 90 degrees away from the bleb. You give your antimetabolite as much. It should not in any way involve the bleb area. However, I've read some few school of thoughts that have done some crazy things that you actually give intra bleb, but that's not for this discussion. The standard is away from the bleb. Look for the offending vessel if you can and give it around that area. Thank you.
So can I share my experience here?
At what interval? Yes.
Actually,
please,
I am the fan of 5AVU. I give 5AVU a lot. And to be honest, I would place the needle, like say 90 degrees away from the blade, but the tip of the needle almost get into the blade and then inject. And that's what has been my practice. So in essence is that the 5AVU somehow get into the blade. And you can see when you do needlings, you also give 5AVU into the blade. So that's why I'm not bothered. And we have been doing that for quite some time. We don't have any issues. Because sometimes I've been thinking 180 degrees, it means if you are giving it 180 degrees, it means you are giving the 5AVU inferiorly while the blade is superiorly. That's 180 degrees. So I really couldn't. So my mentor that taught me 5AVU, he gave it right into the blade. And that is what I've been practicing. And I like the idea of Sarime of trying to identify the bezels. But you see, when you have multiple bezels, multiple bezels around, which is mostly is the case, you will see a lot of corkscrew bezel. I don't know which one you are going to target. So and it's very common among our people. Today you do Trabec, 1 week you see massive vascularization. And that's common among young people. But that's my experience actually. Thank you, ma'am.
Thank you, Dr.
Thank you. Professor Yes, ma'am. Professor Awoyesiku, please. Can you add your voice to this?
Thank you. Okay. Yes, for me, I give 90 degrees away. I do not give into the bleb. And I'm not a fan of giving into the bleb at all. So that's my own school of thought. That's how I was taught, and that's how I practice. I truly, I know that you needle, and I've heard people give the 5F into the bleb, but I've never done that, and I have never taught my residents either to do that. I would usually give 90 degrees away.
Thank you.
From.
Yeah, I would like to add my voice also.
Share my thought. Can I share my thoughts?
I would like to say,
Professor Bonaya.
Yes, I give 90 degrees. I don't give into the bleb. I've never thought it safe to give right into the bleb. But if you give 90 degrees, it's close enough. I think it's close enough.
Can I share my thoughts?
Okay, Dr. Nathaniel, yes, you can speak.
Yeah, sorry that.
All right.
Thank you, Dr. Saramia, for actually crossing the boundary and doing extensive work for us. For anti-metabolite, depending on which one you are if I'm using the 5FU, somebody device is disturbed in place. Somebody device is disturbed.
It's off now. Thank you.
Continue.
Yes.
Hello. Okay. So depending on which anti-metabolite you want to use, you can use 5FU or you can use MMC. You inject. Well, what I do is that I inject very close to the bleb, and by the time you use your cutting board, you can spread it, and it actually goes into the bleb, out of the bleb. It's okay, but if you are giving MMC, you actually probably give around 90 degrees away from the bleb. So that one is because of the complication of MMC. So you can also give topical MMC. You actually give topical MMC. You can use topical MMC for like a week, and like 0.004. You actually mix it with Tia Natural, and you give it like twice or thrice a day for a week, and you see that it actually help. So these are the ways that I use depending on the nature of the patient.
All right, thank you, Dr. Natalia. Prof. Mark, Professor Onokoya. Yes, ma'am. You have the floor, ma'am.
Ma, we can't hear you. Your network seems bad. Maybe you move a bit.
Maybe I should call. Okay. Professor Olushola, I saw your hands up too. While we are waiting for Professor Onokoya.
Go on. I just want to give some closing remarks. Just go on with the questions.
Okay, ma. Thank you. So, okay, ma'am. Another question says
I think
that
Prof is on.
Yeah.
I thought I heard her voice. Professor Onokaya. Okay, it's network problem. Okay, please go on.
Yeah, can you hear me now?
I can see Professor Obonaya's hands up.
Hello.
Yes, my hand is up. Yes, actually, but when we move from this subject, I would like us to talk about children, unless we want to have a special session for them, because I don't know about you, but I do a lot of childhood glaucomas, even babies 3 months, 4 months. And sometimes I have questions and I wish I had people to discuss with. Maybe when we are done with the questions and the platform, we can share our experiences on congenital glaucomas. I mean, our trap.
Okay, ma'am.
Oh,
you have just one question left. Yes. Professor Onokoyama, you have the floor. Hello, ma'am. Ouch. Question that you said the releasable suture could be a needles of infection. Should one attempt to remove them always, even if intraocular pressure is optimal or low? Dr. Sarimiye.
Yeah, thank you. You know, when applying your releasable suture, there are two basic techniques. One, you can allow a loop of the releasable suture lie on the cornea, while the other is that the loop is actually buried under the limbar conjunctiva. So in the second scenario, there is no exposed releasable suture. In that case, you can leave it. If you want to release it because you need to modulate your pressure, then you go underneath the conjunctiva, tease it, and pull it out. But for the first one, whereby your loop is resting on the surface of the cornea, that releasable suture has to be removed. By maximum 3 weeks or 1 month after your surgery, if you release your releasable suture, your primary purpose then is not to achieve a significant drop in pressure. At that time, you are releasing the releasable suture to maintain flow or to remove it because you don't want to keep that loop. That will be a nidus of infection. Over time, if that loop is there, you have some discharge that may aggregate there. If organisms may start accumulating there, and they may just track through that releasable into the bleb space, and that is a possibility or a possible cause of blebitis. So for the second one that has that loop on the cornea, you have to remove it. But for the first one, that while you are doing your surgery, You ensure that the loop is covered by your conjunctiva, the limbus. You don't need to remove it at all. I hope that's clear.
In fact, Sarame, you are very, very correct. In fact, I'll look at my picture and share in the group. We had a case who had trabeculectomy with reservoir suture and having disappeared. The next thing he came with was balevitis and some form of hypothion. We are lucky that time we had some strong antibiotics. Somebody traveled and came back. He did well. We excised the bleb and removed the reservoir suture and did conjunctival advancements. But it's really, really agree with you 100%. I'll look for the picture. I have the picture. I will share with the group sometimes later.
Okay, thank you, Dr.
Okay. Beside that, can I say something?
Yes, Dr. Nathaniel.
Yes, I think the ocular hygiene by the patient is the main factor right there. You know, if the patient has a poor ocular hygiene, it actually becomes riskier, you know, leaving the label suture for a long time. And if for those patients who probably have maybe blebitis or this thing, if you take their history very well, you may notice that they actually have poor ocular hygiene. You know, and most of these patients, especially those illiterate patients from the villages, farmers, we have to be very, very careful how we actually use reusable sutures on them, because some of them may not turn up very well for follow-up, and it becomes a induce for infection. So we have to be very, very careful for those ones. So what I do that once I know that you are coming from the village, you are not very literate, I try to avoid reusable suture as much as I can.
So, sir, is there anybody with experience of laser suture lysis? Anybody with experience of laser suture lysis?
Well, when I was with I Foundation, I think we actually do using laser to lyse it. Yeah.
Yeah. Okay. Even us. Well, that was not.
At what interval?
You say what?
Even immediately after post-op, or what duration do you do suture lysis?
You have to be sure that you have stabilized your intraocular pressure. Once you are sure that you have stabilized your pressure,
yes,
and everything is going on well, and perhaps when you try to do it at the slit lamp and it's not, you know, at times you want to remove it at the slit lamp, it tends to be strong. Then
how
you
many
can use
times and at what interval
laser.
should Thank you. Dr. Sarimie.
I'm with you.
Another question for you, please. Yes. How many times and at what interval should we give subconj 5FU?
You can actually, there are different school of thoughts, but one that I do is to give 5FU on the average at an interval of every 72 hours to give 2 to 3. Now, the reason to give 2 to 3 is dependent on the performance of each injection. When you give injection, 72 hours later, you evaluate. If you can see some regression of the offending vessel, you can repeat the 5FU and we give a third one. But when after the first and second, there is no change at all, there is no point giving a third one. You may need to think of other options to give. But I give up to 3 doses. I don't give beyond 3 doses, usually around 72 hours interval. Some people say every week. Few people say every 48 hours, but I give around every 72 hours interval for the 5FU. Thank you.
All right, thank you very much. Professor, I want you to, please, I don't know whether you want to make contribution to this.
Okay, I do the same thing. I give every 72 hours, but I've also given once a week for 3 weeks. So I think it depends on what you're seeing in the patient. And I usually would like to start giving it in the second week, depending on the vascularity of the conjunctiva. But most commonly, I give 3 doses every 72 hours. That's what I do. 0.1 mil.
Sorry, if I may just say something. I don't know if you can hear me now. Yes, we give every day for 3 days continuously. Can you hear me? So in fact, it's almost turning to like routine for us because most of our traps, once we notice that vascularity, as Sadiq pointed out, we just go straight and give them 3 doses of 5 FU, 5 milligrams, in 0.1 mil. And we give it adjacent to the bleb. And they do very well. In fact, there's a patient that is like end stage and the pressure was down, then suddenly pressure started going up. And we gave it. And for all those we've given 3 days consecutively, they've done very well. All their pressures are back down and vessels disappeared. So I don't think there's any hard and fast rule. Whether you give on a daily basis or give 72 hours, whatever you have seen that works for you, just practice it, But I think 5FU is really finding its way back, for youth. We all went away from it and we're using mitomycin C, but it's proven to work very well.
Yes.
Thank you. Sorry, I'm in a
Thank you
noisy
very much,
environment and my earphone.
Yes, ma'am. Yes, ma'am. You have the floor, ma'am, Professor Chuka.
Yes. Okay, yes. Thank you very much.
Yes, ma'am.
Yes. I have given 5FU daily, just like Professor Onokoya pointed out. 3 consecutive days, but I give in the inferior bulbar conjunctiva. I don't give close to the wound because I'm scared of it ever getting into the anterior chamber through whichever. So I give that. And sometimes when I'm doing that, I'm also doing a gentle digital massage, to keep that bleb, to keep pushing through. So not very firm, just gentle massage, gentle. Put my finger there, count 1, 2, 3, 10, and as I'm giving the 5FU daily for 3 days, and it works. You find out the patients come up with low diffuse avascular bleb, and I'm quite pleased with that. Thank you.
All right, thank you very much. And the last question says that, would subconjunctival Depo-Medrol be helpful for patients who wouldn't comply with topical drops? Dr. Sarimiye.
I think you can mention that.
That has been mentioned. Yes, it will be helpful.
Yeah.
But we also need to understand and be sure of the patient hygiene also. And not everybody will give Depo-Medrol subconj. We have to be sure that, yes, not someone that has, maybe diabetes, you now want to go and give that, you're increasing the risk of having a nidus for infection too. So fine, you can give, but you have to has to be patient selected. Not just because you feel this patient may not comply. Next thing is Depo-Medrol. Does this patient really qualify for this Depo-Medrol? The benefit for this Depo-Medrol outweigh the possible risks. If it is, why not? You can give. That's an option too. Thank you. But it has been answered earlier.
Yes, thank you very much. I would like
but
to call
also
on...
to say, sorry, that it could be a source of
ma'am.
infection, the Depo-Medrol. So we really have to be careful. It's there and it's slowly eluting, but sometimes it could be the source of infection in that patient. And before the chairman gives her closing remarks, I want us to go with a pattern shot. And that is because I've noticed recently, like at the AMPA, we did some tubes, we did some trabs. Would you believe that the tubes are doing better? So should we consider looking in that direction, maybe to make tubes, particularly for those patients that you cannot follow up closely? Because you'll agree with me, you can't do a trabs and go to sleep, because you need to follow that patient at least for the first 3 weeks. Whereas for tubes, if it's well placed, you can give the patient drops and go to sleep. So I would want us to ponder on that, to start considering. And if we do it, the more, we might find an avenue whereby these tubes will come to us cheap, because now it's not cheap, but we can find a way around it. Thank you very much. The chairman, you can make your remarks on that as well.
Thank you, ma'am. Sorry, there's another question, please. The person says that, what are your thoughts on the use of antivirgel in highly vascularized bleb? Dr. Nathaniel.
Okay. Thank you very much. Well, studies have shown that it's not as effective as 5FU and or MMC. Some surgeons have actually used. I've not actually used that for trabeculectomy. I've not done that. So, but the literature have shown that well, it actually could help. You know, especially at times, even when you give MMC for like 3 weeks, you discover that things are not really working well. The vessels are still looking angry at you. You could try anti-VEGF, and who knows, something can happen, and it can improve reduce it a bit, and help to revive your blood. That's my.
Thank you. What about Dr. Tara? I don't know whether you
Hello.
want to add anything.
Yeah.
Yes, Dr. Sarimiye. Do you
Yeah,
have any addition to that?
just to say that the studies have shown that the anti-VEGF are not as effective as our typical anti-metabolite, and they are more cost involving. So there's really no point to chase after it. In our environment, it's better we continue with the anti-metabolite. If you have anti-VEGF free of charge and you want to be using it, why not? But the effectivity is less than the typical anti-metabolite. Thank you.
Thank you very much for this extensive, elaborate discussions. We thank all our presenters from first day to today. I would like to call on the coordinator of the CME of GSN, Professor
Before the
Awoye,
coordinator
to carry on
talks,
today.
please let me say a few things.
Okay, sir.
Professor,
Yes.
Yes,
I
ma'am.
wanted to ask a question or something.
Yes. So just to say that this has been an excellent presentation and session. If you leave Dr. Sarimiye to keep talking about glaucoma and trabeculectomy, I'm sure he'll keep us here for 48 hours. So it's been excellent. It's been deep, extensive, and we just want to say thank you to you, Dr. Tarela Sarimiye. Thank you, Dr. Nathaniel. Thank you to the moderator as well. And we are very grateful to the CME committee or the training.
Dr. Sakama.
Hello? Hello?
Yes, well, I said Dr. Saka, the coordinator.
Yes, Dr. Saka, the moderator. We say thank you to you. We appreciate you. Thank you. And of course, we will thank Professor Elizabeth Awoye-Suku and her team that have put this together. Thank you so much. Just to wade in a little bit and to sort of wrap things up for us, most or all of what Dr. Sarimiye has described comes under what we call active bleb management. You have to actively manage your bleb. This is very important as we continue to encourage people to do trabeculectomy. The other thing I would want to say is that sometimes you have a deep anterior chamber and the intraocular pressure could be low. In such situations, once you are sure there are no other issues, just leave the eye. With time, it will build up. The important thing is the depth of your anterior chamber. Once the depth is good, then the complications of hypotony, maybe your pressure is 5 or even 4, usually they build up. We just watch and wait, and you can reduce your steroids and just see what happens. I wanted to make a comment on autologous blood. Now, I have never used it, but I've seen a patient who was referred to me that was giving autologous blood straight into the bleb. And there was so much overwhelming inflammation. The inflammation was, I don't think I've seen that amount of inflammation in one eye. And the patient lost the eye. It was because the patient had hypotony in the eye, that they gave the autologous blood and, the inflammation was unimaginable. I imagine that most of the publications on the use of autologous blood have been done in Caucasians. They don't have a lot of inflammation as we do, so we have to be very cautious with the use of autologous blood. I wanted to weigh in on the tube. Yes, tubes are less stressful. Tubes give you, good results and all of that, and they are less stressful in terms of postoperative care. But when we look at the ladder of glaucoma management, once you have put a tube, doing a secondary trab or, doing another tube, one will now begin to look at, pros and cons, especially with two tubes in the eye or even 3 tubes in the eye. Usually they have corneal decompensation with time, and, the patient usually are not just comfortable in the eye. So we have to be a bit, as we think of maybe tube as primary form of surgery, I would still want to say the ladder, because this is a lifelong thing. If you do a trap that it fails, you go to a tube. One tube fails, then you do 2 tubes. Then that 2 tubes fail, then you try to do other things, and that ladder and sequence can also be helpful. Of course, if it is an elderly patient, I have done quite a bit of primary tubes for quite elderly patients because I know that it's likely that the tubes will last them for quite a long time, and they may not need all the years that a young patient would need. Be that as it may, I think this has been an excellent session, and I would want to thank the presenters and the moderator and the chair of the GSN Training Committee. And I also want to thank all our elders here. Professor Monokoya, thank you so much. You have been with us all these 4 days of
yes,
sessions.
Thank you, ma.
We are really, really grateful. I mean, this is awesome.
Dr. Morgan.
Professor Chimdi Chukaokosa, thank you so very much. You have been with us contributing, helping, assisting, and just being there for us. We say thank you. Professor Regina Morgan, wow, I can't imagine. Yes. I mean, there's just no way I can talk about this. Professor Morgan is in a very different time zone. And the time zone is really not convenient for anybody who will be in that kind of time zone. Yet she joins us all the time. We really appreciate you. Thank you so much, ma. We thank all of our elders who are here, who have joined us all through this time, supporting, giving us their ideas, sharing with us their experiences. We cannot thank you enough. I don't know if Professor Kizo Akaraiwe is here, but if she is, I say thank you so much. And of course to GSN. All the members of GSN, you've been wonderful. You've been awesome. Thank you so much for your support. And thank you so much for being here. We thank you. We are very grateful as GSN. Let's continue the hard work. Let's continue the hard work. Let's continue to train and retrain. Let's continue to educate ourselves. Let's continue to get better at what we do. And I know that we'll have a better united front as glaucoma specialists in Nigeria. Thank you so much, everyone, and have a good evening.
Thank you very much. Professor Awoyesuku, please can you round up for us?
Okay, so thank you, everyone. This brings us to the end of the Zoom meetings for the training program. From next week, we are going to go into the in-person training. There's several centers. I think we've already put that up on the floor. We'll start with the wet lab, and then we'll also have the actual hands-on training. And of course, this promises to be an annual event. So we are hoping that we'll be able to continue this training until everybody has been trained or retrained. And who knows, we may also decide to add tubes to it because there's so many people that want to learn tubes. And I mean, as a glaucoma specialist, you should also add that to your arsenal so that when traps fail, you should be able to move on to tubes. And I'm sure GSN is going to be on the forefront for that. So thank you so much. And for the participants who are going to go on to the training centers, I wish you a safe trip, and I wish you a good training session, and do share your stories. Let others also learn from you, and we'll continue to make sure that we take Glaucoma Society to the heights that it is supposed to be. And at the end of the day, every glory will continue to go to God. Thank you so much for being with us. We appreciate
Just
you
to say,
all our seniors. We appreciate you. Sorry,
no,
Professor Lawoy, you should say the last blessing.
No,
so I
I've
don't
said
break
the last.
protocol.
I've said the last blessing, please. It's fine. I just
I'm done.
wanted to
You
talk
can say the
around
last one.
Professor Chimdia's question. She wanted us to do childhood glaucoma.
Okay,
and I think we should have that
yeah.
session another time very soon.
Yeah.
By God's grace. We will have that
Yeah.
session. Thank you. Yes.
All right. So thank you, everyone. We appreciate you for even coming out on a Saturday. Supposed to be doing some less stressful things that are not academic, but you spent time with us. We really appreciate that. So do have a lovely rest of the weekend and an amazing week ahead. Thank you so much. Bye.
Thank you.
Bye-bye.
Bye.